Calhoun on volunteering her time to come educate us a little bit more about the lung transplant. So I'd like to introduce Dr. Calhoun. She's with our Center for Comprehensive Lungs. She's a pulmonologist that joined our organization. How many years?
Well, I did my fellowship here in my training, but I've been officially on faculty with the lung transplant group for a little over a year now.
That's awesome.
So
that's awesome. So thank you for a round of applause.
Thank you. Thank you.
I'm gonna control your.
Oh, I can do it too. Yeah, there's a lot of animation, so okay. I don't want
And then I have this here. Oh, can you hear me?
Louder. Oh, I can also take off my mask too. Is this better? Is this louder?
So this is for the recording. We're recording this.
Okay, perfect. Okay, never mind. I was like, it doesn't sound loud to me, and I can project quite well. I'm quite loud. So yeah, I'm so excited to be here. I'm so excited to see so many familiar faces I haven't seen in a while and doing so well. So today I'm going to talk about how to kind of prepare for lung transplant. I have a lot of experts in the room who have gone through this process, so please speak up and give your own opinion. Whenever I talk to patients, I also say the best asset is talking to someone who went through it. I can counsel you as a pulmonologist, but it's invaluable to talk to someone who's been through the experience themselves. So the majority of the presentation will be kind of like how to prepare for the process of lung transplant. Then I'll give a brief overview of kind of like the process, and then briefly what life looks like after. I don't have that many slides because I really wanted this to be interactive. So please, please, please stop me if you have questions in the middle. Just raise your hand, whatever, because I guarantee if you're thinking it, someone else in this room is probably thinking it too. Okay, so I like this to be as interactive as possible because, like I said, I don't have a ton of slides to go over stuff. Okay, but the agenda, like I said, I'll first kind of talk about who gets a lung transplant, who's a good candidate. Next, I'll talk about what diseases commonly get transplanted. I obviously heard a lot of them, honestly, all of them that I'll kind of talk about, but just to give you an idea of that. I'll talk briefly about single versus double lung transplant, okay, and kind of the differences and what I call the pros and cons of each, because they're not true pros or not true cons. It's just something to be aware of what to expect, okay? Next, how to prepare for lung transplant in your potential evaluation week and what that looks like. And then lastly, like I said, I'll touch on life after lung transplant, again, with some experts in the room who can give their comments and feedback on that as well. Okay, so let's start with who gets a lung transplant. So I counsel patients, the perfect candidate or the person that I think of who gets a lung transplant is someone who has end-stage lung disease. And you might hear us pulmonologists throw out that word a lot. And what does end-stage really mean? And it really means that your lung disease, whatever it is, has progressed to the point where you are very symptomatic, okay, and you're probably on multiple medications. The type of medication will, of course, vary by your type of lung disease. But again, it's someone who is not very early in their lung disease, not someone who is barely symptomatic, but someone who has a lot of symptoms and on medications, okay? And more importantly, I would say, is that we start thinking about, okay, now's the time for lung transplantation when your symptoms are worsening despite adequate medication. Sometimes what I see and what I saw when I was a general pulmonologist is that someone who would have COPD and they would be very symptomatic and they would just be on albuterol as needed. And I'd be like, that's not enough. That's not enough, right? You need to be on a different inhaler. You need to be trying this. You need to be taking it multiple times a day, right? So sometimes there's a window of opportunity where I can optimize or change the medications to help people feel better. That goes from not only the type of medication, but also the delivery. So I don't know, some of you might be on nebulized medications, et cetera, and that can be a better way to deliver the medications to help you not be as symptomatic. But if despite those medication changes and you're still having those symptoms, so I say, okay, maybe it actually might be time to think about lung transplant. And these are conversations you should be having with your primary pulmonologist if you're not already seeing us. The other major thing that I talk to patients about is frequent hospitalizations. If they're telling me that they're going to the hospital multiple times a day, or not multiple times a day, my goodness, oh my goodness, no, multiple times a year, that's when I'm like, okay, again, something is poorly controlled. You are progressing too much. Again, this might be a sign that transplant is nearing time for transplant, okay? Not a surgical candidate, okay? This is more for patients who have COPD. So some of you might be aware that there are some surgical interventions that might be able to help people who have advanced COPD. One of the more common ones we talk about is valves, where we actually go in through the bronchoscope and we put in a one-way valve, essentially in the part of the lung that has too much air stuck in it. The COPD, I always tell people it's a sensation or it's a disease where you have too much air inside and you're so full of air that you can't blow it out, and then you try to take another deep breath and you can't because you're already so full of air, right? And so what the valves do is that it helps you kind of release or not build up as much air in that area of the lung, okay? It's a much less extreme, because I'll be honest, lung transplant is in some ways extreme. Oh, you're okay. It's another option that you might be able to buy you more time, improve your symptoms, okay? So if we're able to do an easier procedure like putting a valve in, we often will try that before doing lung transplant. In the event that you put the valves in and they don't work that well, it's okay. I mean, it's unlucky, unfortunately. We could take them out, still a transplant candidate. It's not going to interfere with any of that. So if you do have COPD, you're on the medications, make sure you're talking to your doctor and say, am I a candidate for a valve or some sort of surgical intervention? There's certain contraindications to it, which I won't get into today because it's outside of the scope of what I'm talking about today. But if it's not been brought up to you, you should mention that to them and make sure that they've at least thought about it. They might have just not said it to you in the short, kind of visits we have, but make sure that they've at least thought about it, okay? The other one is decreased life expectancy, which again, is usually a combination of all the things I've just talked about. You're in and out of the hospital a lot. You're not breathing very well. And we are concerned that, this disease could be reaching a point of it being terminal, okay? That's when we say, you know what? Now is probably the time that the risk of transplant makes sense, okay? Another thing which I'll get into a little bit when I talk about the evaluation is no other major medical problems. The main ones that I'll talk about today is kidneys, because as my post-transplantation knows, some of the medications you take after transplant are harmful to your kidneys, and it's the cost of doing business, okay? It's the drugs that work the best for preventing rejection and having the lung transplant last the longest, but it can hurt your kidneys. We have options that we'll play around with after, but if you're already coming in and you have really bad kidney function, it's only going to get worse. And I tell patients, if I am concerned that a lung transplant is going to put you on dialysis, I don't think that that's a good trade, okay? Unfortunately, dialysis can be a consequence of lung transplant despite our best efforts. I'll briefly touch on that. But if I go into it knowing that's a very high likelihood or expectation, it's probably not a good idea for us to move forward. So that's one of the major things that we think about. The other thing is cancer. The drugs, again, I'll get into this a little bit later, that we give you to help keep the lungs healthy and working. One of the side effects is that it makes you more prone to developing cancer. So we are very big on our cancer screenings after you get a lung transplant to make sure that you don't develop them. More common ones here in Colorado are skin cancers, okay? And sometimes you have to have those removed. But if you already have a small cancer or an existing cancer, it's only going to get worse. So that's going to be another one that we really keep an eye out for. And if we see that, we're going to say, oh, it's probably not the best idea because it's going to make things a lot worse, okay? So those are some of the things that we think about when thinking about a good candidate for lung transplant. So again, someone whose disease is advanced enough that this makes sense, okay, and also doesn't have any other issues going on that's going to get worsened, we know for sure, with transplant. Questions about this real quick before I move on? All right, so medical conditions that we do transplant. Again, I've touched on most of these, and I think everyone in the room had one plus maybe a bonus one. But COPD is one of the more common things that we transplant for. So, right, smoking-related lung disease, or you'll hear it too, emphysema. And so again, this is a problem where you're not able to really blow out all the air that you have, and you feel too full, and you can't take a deep breath. So in comparison to ILD or IPF, and I know that you've had other meetings on this. I believe Dr. McLafferty talked about ILD probably several months ago now at this point. And that's interstitial lung disease or idiopathic pulmonary fibrosis. I've lumped them together. So again, out of the scope of this talk today, ILD, I often call it an alphabet soup. And your doctor will probably say, oh yeah, you have NSIP or UIP or RBILD. Not important. It's more for us in terms of like an academic center and us being thoughtful about how to treat it, and what medications you should be on, but they're all grouped under the broader category of ILD. I pull out IPF, which again is under that bigger umbrella, idiopathic pulmonary fibrosis, because it's idiopathic, as in we don't know what causes it. It tends to run in families, and then it can be very aggressive. And so it can be treated, or I look at it slightly different than the ILDs because of that. So people, when they're diagnosed with IPF, some people just kind of linger, maybe need a little bit of oxygen here or there. Nothing really happens. They don't really get too sick. They also don't get better. Some people, unfortunately, with IPF get sick very quickly, need transplant like this. Okay, so it's slightly different, can be more aggressive, and so that's why I kind of pull it out as like as an additional thing to think about with ILD. Next one, cystic fibrosis, which I guess is the one I didn't hear. So cystic fibrosis, again, it's a genetic disease. People are diagnosed with it at birth with our screening processes that we have now. And it can cause a lot of recurrent infections and also lung disease. These tend to be our younger lung transplant patients because, again, they tend to have very severe symptoms in childhood and into the teenage years. So these are, if you meet any of our patients who have been transplanted who are in their teens and 20s, they probably have or had cystic fibrosis. There's now better medications that are actually extending the life expectancy of cystic fibrosis, so we're transplanting them less, which is great. Or we're able to, push it off for longer. But it used to be one of our more common things that we transplanted for. And again, we're not seeing it quite as much due to advances in medication, but still a major one. And then last but not least, pulmonary hypertension. So pulmonary hypertension is increased pressure in the vessels of your heart, basically are going to your heart from your lungs. And so this can develop on its own. So it can be a genetic disease. What you might have heard more of it is in the setting of lung disease. If you're not using enough oxygen, it can put a lot of strain in your heart, which causes those vessels to constrict. Okay. So a lot of times I have patients with pulmonary hypertension because of their ILD or IPF, or because of their COPD. So it might be that you have a combination. I heard someone say that they had both, a combination of these things, or you might have it in itself. If you have it because of lung disease, it's a little bit more intuitive of why lung transplant makes sense. Take out those bad lungs, pop in some new ones. The pressure issue is kind of resolved, okay, and you don't need as much oxygen. When it's we transplant for it alone, if it's a genetic disease or from some other cause, like medications can do it, etc. When you have the lung transplant surgery, we actually change out some of those vessels in the process of how the surgeons actually kind of sew things in. So you're also getting rid of the pipes that are too tight. And so that's why it makes sense if you just have pulmonary hypertension and no lung disease. Okay. So that one's a little bit more, I say nuanced in terms of when it makes sense to transplant these people, because again, they're not on the traditional path of these other lung diseases, but it is something to be aware that we transplant for. And then of course, if you have a combination, a lung transplant will fix both problems, which is fantastic. Okay. All right, single versus double lung transplant. I feel like in our pre-lung transplant clinic, I get this question a lot. And feels like there's sometimes a lot of feelings about it. So I want to kind of talk to you now and kind of let you know from my perspective, the difference and why, and from a pulmonologist perspective, how we kind of go about deciding which one we're going to recommend for you should you move forward with lung transplant, okay? So I'll start with a double lung transplant. So as the name implies, again, we take out both bad lungs and replace them with 2 good lungs from the same individual, okay? From the same donor, I should mention, okay? Some of the pros, okay? In a particular patient, it might mean that you have a longer life expectancy. And what I mean by that is, in general, double lungs, both sides, last a little bit longer than a single lung. There's a caveat to that, though. It all really depends on your age. So right around the 65-year-old mark, that difference stops being as apparent based on studies. So if you're younger than 65, we're going to advocate for you to get a double lung transplant so that it lasts as long as possible. If you're over the age of 65, and I'll kind of get into this a little bit, you might not actually be getting the benefit of that extended life expectancy with lung transplant, and it might make more sense for us to do a single. But again, I'll talk about that, okay? It's not guaranteed. And as we've kind of mentioned, there are people who've had single lung transplants and live just as long, if not longer, than people who have a double lung transplant. That's kind of what we think about when we are thinking about some of the differences. That's one of the more important things, obviously, to you all, right? It's also much better if you have a lot of lung infections. So this is again kind of talking about these patients, especially the one that comes to mind is cystic fibrosis. So cystic fibrosis happens because basically the motility factors in the lungs that help you clear mucus, so the things that kind of help when you cough, actually cough up stuff, don't work, okay? And so people get a lot of mucus in their lungs that they can't clear. Might also have a similar issue if you have COPD. You just always feel full of junk and you just can't get it out. When that happens, you are more prone to infection because that mucus just kind of sits in there and gets infected and inflamed and you get sick. So if that's happening to you a lot and we take out one lung, well, that solves the problem in that one lung, but the medication we give you can make you sometimes be more prone to being sick. So if you have one lung that's still always full of sick mucus that's infected, it's going to constantly cause you to have infections, okay? And so if you have a lot of infections or there are infections that are really difficult for us to treat, if possible, we opt to get both lungs out so that we're not having to deal with that other lung that's constantly having infections, okay? The other one, I don't think I added this on my slide, is that if you have pulmonary hypertension only, and especially if you're young, again, it's those pipes kind of like on both sides of your heart and lungs. You got to take both those pipes out to have a good impact. So if you have especially pure or really bad pulmonary hypertension from your lung disease, we're not going to get full treatment of that unless we do a double lung transplant and get both sides out. Okay. Now let's talk about the cons. Okay. I only have one bullet point here, but this is like, it's a major con, if you will. Okay. The recovery can be a lot harder. You're taking out both sides, right, versus one side. Your incision is going to be larger. The surgery is going to be double the amount of time. And what I mean by that is magnitude of 6-8 hours plus in the operating room, right? It's a long time to be under anesthesia. It's a long time for things to go wrong. Okay. And so I don't mean to downplay this. Like, it's a major con, if you will, is that you're going to be in the hospital longer recovering, and that there's higher risk for complications. Now, a lot of people, and maybe even some in this room, like, got it and bounced out of the hospital. They're like, bye, see ya, it was great. Most people, though, have what I call a speed bump, right? Whereas, like, they get the procedure done and things might initially be okay, but then we have maybe a little setback and we're having to do some stuff. So point being, longer, more difficult surgery. So if you do maybe have some of those other medical issues I talked about, right, like your kidneys aren't so great, I don't know if it's a good idea for us to put you under anesthesia that long. There's a lot of opportunity for your kidney function to get worse just from the surgery, okay? And as well as like the bleeding. So some cons, if you will, some pros. These are things that we think about when we're evaluating you and discussing you as a whole person, okay? So on the flip side of things, a single lung transplant can be a left side or right side. We decide that based on a couple factors, mostly if there is anything concerning. So like say you have a little nodule that you're looking, or that your doctors are following on the right side, that might have us favor doing a transplant on the right side so we can get that nodule out with the bad lung done, okay? Versus if you had a lot of chest tubes or trauma to one side of your lung and that lung is pretty scarred, we might favor taking out the other lung because that one will be easier to take out. So left versus right will kind of depend on your body, what's going on, but we can do either. One of the pros I haven't talked about, or I haven't listed here, that's important, is that we can do more lung transplants of people who's being single. That's not why we do it, but in one donor, a lung can go, the left lung can go to someone, a right lung can go to someone. We can transplant more people just based on the numbers game. It's a shorter surgery and easier recovery because all that stuff I just talked about with the double, it's half that, presumably, again, as long as things go okay in the operating room. Half the amount of time in the surgery, half the amount of time you're on anesthesia. You have the incision in general is only half the side of your chest. A lot of people who've gotten a single are like up and moving, doing great real quick. And that's what can be really nice from my perspective, because I'm like, oh yeah, you already feel the benefit, you already feel better. And so you're usually in the hospital for a shorter period of time, okay? Because there's more organs, like I mentioned, it can also mean you have a shorter wait list time, okay? So if a double is going to a patient, then obviously both lungs from the donor are going. If it's only one side, then the other side's up for grabs. Okay, and so there's usually more organs available for us to get you transplanted sooner. So if you're really sick and you're on the older side, I'm like, we should maybe think about a single, and we can say right or left, doesn't matter to us if it's, good with your body, and we can sometimes get you transplanted sooner. That also is a strategy you might hear us say if you're on the lung transplant wait list a long time. And the long time is all relative. But if you're on the lung transplant for months and months, which actually is a pretty long time, we'll say, you know what, we should maybe consider a single so that we can just get this done and get you feeling better sooner. Okay. Cons. You still have one native lung, which actually is okay. Our bodies, whether you believe in a higher power or not, have redundancy, right? It means we have multiple of important organs, okay? You have 2 kidneys, you have 2 lungs, you have 2 eyes, not 2 brains. That's probably the only important one you don't have 2 of. But it means that, like, you only need one good one. You got one good one, you're okay, okay? Um, the the problem is that sometimes if you do have a native lung and it's full of infection, as I mentioned, that can cause us some problems. But if you have one transplanted lung and one lung with ILD or IPF, it's okay. The one lung with ILD and IPF will continue to progress. It's okay. It's just going to get worse and worse and worse with the inflammation or the scarring. But our bodies know to preferentially give oxygen and blood flow to the good lung. It's actually physiologic of how it works. So your body will siphon all the important stuff to the good lung, okay? So it's not as big of a deal as you might think or how it might sound, okay? A reasonable expectation is to be off oxygen, just like with a double lung transplant, et cetera. I never promise off oxygen with either one because sometimes things happen outside of our control, but it is a reasonable expectation to be off oxygen, have a great life expectancy, okay? I feel like when I sometimes talk to people, I say I'm recommending a single, they get nervous and like, I want a double. And then I explain why we're making this decision. And then afterwards, they almost always come back and say, you know what, Dr. Calhoun, it was fine. I got transplanted faster. I feel good. It wasn't a big deal. Okay. We make all these decisions and make recommendations for you in a big group of people that we call our selection committee, which I'll get into in a second as well. But it's not just my decision about things. It's a whole group, including our fabulous medical director, Dr. Gray, who I know a lot of you know and love, as well as a bunch of our surgeons, our dietitians, et cetera. So we, our social worker, we all come together and we talk about, in this individual patient with their health problems, which one makes the most sense, okay? And we come to a consensus, and that's what we recommend and move forward with you on. Okay. Questions about double versus single? Okay. And again, if you're above 65, the studies show that the life expectancy is the same whether you get a double or a single. Okay. All right. How to prepare for your lung transplant evaluation. This might be, and again, those of you who've gone through it, let me know. But I hear people, this can be like an exceptionally stressful week. Okay. It's very, very busy. But the point of what we do is just to kind of get you prepared mentally for transplant. So talking to a bunch of different people, as well as kind of do all this testing to make sure there's no little things that we don't know about that are going to cause those problems after lung transplant. Okay. So an evaluation, it kind of comes in 2 different types, and we base this based on how sick you are. So if your pulmonologist refers you to us and you're not that sick, relatively, we'll do what's called an initial evaluation, where it's kind of like a meet and greet. You come in, you chat with us, I tell you all this stuff, and in a longer period, like a 1-hour visit where you sit down, I talk to you all about lung transplant, what it means, okay? And that's just kind of get your head wrapped around it. And it also is, if you have warning things, I can give you some time to be like, I know you need to work on X, Y, and Z to prepare you. If you're more advanced, so we think that you're actually closer to needing transplant, we do what's called your evaluation week, where it's a 1 week of testing where you meet with us, you meet with the surgeons, you meet with everybody. And it kind of is a more comprehensive week of testing and meeting people, again, preemptively getting you ready to transplant sooner, okay? And so you'll do a bunch of tests, as I mentioned. You'll meet with us, social work, pharmacist, dietitian, our nurses, our wonderful pre and coordinator nurses, our financial coordinator. That's a big one I highlight because the financial piece unfortunately can be a really big deal. Lung transplant's not cheap, and the meds are very expensive. And so if I know that transplanting you is going to put you into financial ruin, bankruptcy, I'm not doing it. I'm sorry, because that's not an option. So our financial coordinator is great to work with us to make sure if there's things that need to be optimized, fundraising, to make sure your insurance is okay, and all that sort of stuff. So super important to kind of think about. You will get a lot of labs drawn, like probably more vials than you've ever had drawn your entire life. Okay, we are looking for everything under the sun. Okay, we're looking for if you have a history of rare infections. We're obviously looking at your kidneys, as I mentioned. We're looking at your white blood cell count, your other blood counts to make sure that those are normal. Okay, we are also looking to make sure that you're not doing any naughty things, which I'll get into in a second. Okay. We also do CT scans. Basically, your entire body gets CT scanned, okay? One, we're looking at your lungs. You want to see how advanced your lung disease is. We're also looking at your stomach, pelvis, that sort of thing. The main reason for that is to make sure you don't have any cancer, right, that you don't know about. Because unfortunately, sometimes that's how we find it, is that you have a little spot here or there, okay? And so we want to make sure we know about that going in, and if it needs to be worked up before, we can do that. Maybe your favorite or least favorite PFTs and walk test, okay? Obviously to look at your lung function so we can see how quickly you're progressing or not. The walk test, obviously important to see how far you can walk. Lung transplant can be a little tricky because we want you to be as strong as possible to survive surgery, but sick enough that it makes sense. And so pulmonary rehab is obviously, I'll give kudos to. It's very important here because we want you as strong as possible going into it. And one of those measures that we look at is the walk test, how far you're able to walk during that 6 minutes, okay? We also do GI testing. And what I mean by that is that if you already have an issue with acid reflux, it's going to get worse after transplant, more than likely. So you want to know that about that going, we want to know about that going into it, okay? Heart function testing, so what's called a right and left heart cath. We do that to measure how much pulmonary hypertension you have if you have it. Sometimes people don't even realize they have pulmonary hypertension from their lung disease till we do this test and we tell you, and that might change our transplant strategy. And also make sure you don't have any blockages in your heart, okay? Things that you might have heard referred to as stent placement or something like that. Your heart needs to be strong to tolerate the surgery, okay? So that's why we look into that very closely, okay? So during this week, you come in basically every day and we're doing some of these tests, or you're meeting with somebody and you're talking about transplant for the entire week. And so it's kind of important for you to know that and kind of wrap your head around that. And I can talk a little bit next about how to be prepared for that week of evaluation, okay? All right, so the first one, obviously, I mean, I'm preaching to the choir here because you are all here and clearly invested. But unfortunately, I have some patients who come to me who have never heard of pulmonary rehab or who have never been referred. And I'm like, it's the best thing ever for you to help you feel better and to get you stronger. So pulmonary rehab is my number 1, 2, and 3 thing to get you prepared for lung transplant, okay? It helps you safely exercise, know how to titrate your oxygen. Like it's just so important for you to participate in this pre-transplant. And again, to get as strong as possible and to kind of know how to be using your oxygen effectively, because especially when you first get started on it, it can be a little bit confusing about how to titrate it. My next point, again, linked to kind of pulmonary rehab, using appropriate oxygen. Again, I cannot stress this enough. Not using your oxygen when you need it can be very detrimental to your health. It can cause your heart to not function very well, causing pulmonary hypertension. Okay, it can also make your brain foggy and be like, I can't think very clearly. It's probably because your oxygen levels are too low. Okay, it can cause you to potentially even have strokes. It's so important. So in pulmonary rehab, you obviously learn how to do an oxygen. But if you're the type of person who at home, you just take it off because no one's there watching you, okay, you need to be wearing it at all times. Unfortunately, some of my younger patients, there's a stigma, and I get that, and I do understand that. I don't personally understand because I'm not on oxygen, but I hear you, and I hear those concerns. But for your health, you have to get past the stigma, and you have to wear it. You're gonna feel better. You're gonna be able to do more, okay? And it's gonna be, and your body will thank you, okay? Stop smoking. Oh, yes. Yeah. So I guess a big piece of that is checking your oxygen saturation, okay, when you're feeling that way. Because it might be that usually it's rare that people need the exact same amount of oxygen at rest and when they're moving, right? Because when you're moving and doing more, your body has more demands, you're taking deeper breaths more frequently, you need more oxygen. So in general, people need more oxygen when they're exerting at pulmonary rehab or doing activity versus when they're at rest. And it might be that it is too much oxygen at rest. The risks of too much oxygen are minimal. I hear you sharing your symptoms, or, you feel it, you might be feeling like you're blowing your head off, and I don't want that. But the risks of it, I favor the side of too much oxygen versus too little. Check your pulse ox and see what your number is. Okay. Some people might round and say, above 90. Let's see, the technical is 88. I'm a very technical, precise person. So I tell people 88 needs to be above 88 at all times. So if you're sitting there and you check it and it's 99, you're right. You probably don't need that much, and you can maybe dial it back as long as you're paying attention to what that number changes to. Okay. And as it drops down, if you're like, oh no, I'm 88, 87, nope, that's too little. I need to go back up. Yeah. 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 So I mean, it's one of those. It's a little bit of like a art, and you'll kind of learn how your body kind of feels and reacts. But I always say the pulse oximeter is the pulse oximeter of truth. Okay, no matter how you're feeling, the number is the number, and you need to be wearing oxygen according to the number. Okay, but continuously not using enough, and that number is too low, is very harmful to your body, and you're not doing yourself any favors. I also tell people oxygen is just a number. It's just a number. Like I feel like some people are really distraught. They'll be like, I was on 2 liters, like, and now I'm on 4. And I'm like, it's a marker for us to gauge how quickly you're progressing in your disease, but it's just a number. Don't attach feeling to it. Okay. It's a number that you need and you should use. Where the number becomes very important is making sure that you have enough at home to support you or whatever activity you're doing. Okay. That's when I really care about the number. Because if you in pulmonary rehab are needing 10 liters of oxygen to walk or exercise, and then at home you can't give yourself 10 liters, then that's a red flag to me. I need to change your oxygen prescription so that you can have enough oxygen to do what you need to do at home. Okay. So whatever the number it is that you need is fine, as long as, again, your sats are above that 88 or 90 if it's easier for you to remember a number. Okay. Does that answer your question a little bit? Maybe. But point being is it depends on your body, and the most important thing is that your oxygen levels are above 88%, whatever number that might be. Okay.
Read, I know that makes you already cringe.
Oh,
but
no. Okay.
The optimum level pulse ox for COPD and IPF is different,
Yes.
and that pulmonary fibrosis ILD people should be higher, like 93.
Okay, so great question. And yes, it's a little bit slightly nuanced. So I don't want to get too technical on this, but in COPD, if your oxygen level is too high, because of the nature of the disease, it can sometimes trick your brain into not breathing. Okay, so yes, I tell my patients with COPD, the ideal spot where I want you in is at 88 to 92. That might be what you read, or I don't know, but that's what we're all taught. 88 to 92% is the sweet spot for COPD. Higher than that, again, might be detrimental depending on the person. ILD doesn't have that same mechanism in your brain. So again, over 88%, anything really above that is okay. If you feel more comfortable, 93, 95, sure. Do you need that? Not technically by the books. You just need to be above 88. But if it feels better, it's fine. It doesn't have that maybe detrimental aspect that COPD does.
What you say is, I understand the difference between, the CO2 goals. I understand all that.
Yeah.
But the articles are encouraging people to be 93 or higher with no reason other than if it's like, if you have this disease, you have to be over 93.
Mm-hmm.
And I can't find any explanation, and it doesn't sound like it's an absolute truth.
Yeah, that's probably why it's hard to find.
Yeah.
Because it's not really. Again, some people feel better, are able to do more at those higher levels of oxygen. Again, if you go back to like the cellular studies, like on rats, hyperoxygenation, what we call it. So a C or a pulse ox level of like always 100% or higher or over oxygenating you. it can release like what we call free radicals. Again, it's much more like nitty gritty scientific harm. So I tell people I'd rather you be higher than too low because I know low is dangerous, right? High may or may not be dangerous. And so I think that's where some of the ambiguity can get into. But you did bring up a good point that, yeah, COPD, that might be the one dangerous thing. You mentioned, sorry, you said you had COPD, because that's correct. Okay, that might be the one thing too, is that I don't want you constantly at 100, because again, that could maybe cause you to not breathe on your own as much, but it's, I won't get into that maybe too much more. Does that answer your question? So there's not good data on that. You don't have to be that high, but if you feel better at that high, fine. Also, some people have sometimes asked me like, why 88? Like, where did that come from? Insurance company. Yeah. I can't get insurance to pay for oxygen until you're less than 88. That's where it came from. Okay, so.
Another thing I read is if you have an ILD diagnosis and you have to go to your insurance company because nobody ever separates it out, but the requirements are actually 93 for insurance for oxygen based on the code.
Mm,
I don't know.
interesting.
I never did it.
I have never had success with that.
And it said if you need to do that, that's how you fight it. People were writing that.
Yeah, I don't.
I know they made me be 88.
Yeah.
And for home oxygen.
Maybe there are some insurance companies, maybe, but like maybe, but I have not run into that ever really. It's just 80, it's 88, right? And if you're above 88, they're not going to pay for it. So if you want to pay out of pocket, probably a large amount of money, by all means, but yeah, your insurance is not going to pay for it unless you drop below 88, and we document it, right? Like, it can't just be you telling me you're 87. I got to like watch you walk, watch you DSAT, type it up, because otherwise the insurance people harass me, which is no fun. They already harass me about too much stuff. Okay. Yeah, of course. Did I ever harass you about stop smoking? Maybe, probably. I'll say it again if I didn't. I can't remember now. Don't stop smoking if you're still smoking. Okay, please, please, please stop. It's one of the number one things you can do for your health, no matter what process you're trying to go through. We do check also. Okay, so be honest about that. This is an important one. Take all of your meds and follow up with your doctors regularly. Okay. This is just to make sure that your body's in the best shape possible moving forward with transplant. But it also shows us that you have a record of like doing that. And I get that some people aren't medication people. I understand that. You know, you want to do things the natural way. There's nothing natural about lung transplant. Nothing natural about it. Okay. So you're going to be on medications, which I'll kind of get into it towards the end. So start it now. Get in the habit of being good about your meds. Be organized about it. Whether you use a pill box, whether you have someone who helps you, okay? Because there's just going to be more that are added on after lung transplant, okay? So be good with that. Follow up with your doctors regularly, again, for routine screenings, etc., and just for your overall health. Stay up to date on your vaccines and cancer screenings, as I mentioned. So as you all probably know or have heard, the flu vaccine and COVID boosters are out. I recommend them to everyone, okay? If you have lung disease, you are at higher risk of developing a worse infection that can land you in the hospital and unfortunately maybe even kill you, okay? Really important to stay on top of your vaccine, so please get vaccinated as soon as possible. Cancer screenings, as again I mentioned, colonoscopy, mammogram, pap smear, etc., maybe even a PSA for men. And that's just, again, making sure that you don't have any evidence of cancer, or if you do, that we start taking care of it right away in anticipation of maybe transplanting you in the future. We do not transplant people with active cancer.
Doc, what's the current recommendation on RBS vaccine, especially for transplant?
Oh, RSV? Yeah, we recommend that you get it.
Every 6 months?
Oh, yeah, so sorry. That's still actually in the works. The last I saw, they're still trying to figure out exactly at the appropriate frequency, since it's a newer vaccine. You should get it now, and we'll follow up with you about whether or not you actually need to repeat it later. You might be asking that because you don't know, because you can't find that information maybe, or someone can't tell you, and it's because we don't really know. Yeah.
So basically, if those of us that have had transplants, if we have had one shot, that's good for now.
That's good for now. Mm-hmm. Yeah, absolutely. Okay. Again, I will have to look into, like, where I recently saw as of like 2 weeks ago was I was still kind of, they were figuring out how often the frequency is. And so it'll be one of those things where it shouldn't be, it's not going to be a yearly booster for sure. It'll probably be more like your pneumonia vaccines, where you need it every 2, maybe 5 years, and they're still kind of teasing that part out with the data and all that stuff. Yeah. That's a great, but thank you for bringing that up. RSV is another one. Your pneumococcal or pneumonia vaccines, also super important. Basically, any vaccine that your doctor's recommending, you should take it. Okay. We prefer it pre-transplant too because it allows your body to build up antibodies and a response. After transplant, your body is not going to build that response up, which is on purpose because that's the same response that can attack the transplanted lungs. So any vaccine that you can get pre-transplant, we recommend getting it. During your evaluation, we'll probably recommend other vaccines like hepatitis B, etc. Okay. Don't use drugs. Even though it's legal here in Colorado, which I have to explain to people, no marijuana, okay, definitely don't smoke it, stop eating it if you are, okay. Yeah, it can mess with your levels and all that stuff post-transplant, so even though it's legal here, we do not allow our patients to take that because it can, like I said, cause some problems. So if you're doing that now, start working on stopping, okay? And any other drugs too that you might be doing more hardcore drugs like cocaine, heroin, you'd be surprised. Stop using those. Okay, we do check. And then drinking. So drinking is not good for anybody. Okay. And again, after transplant, it can definitely cause some drug interactions. So we're going to ask you to stop drinking when we see you in our lung transplant clinic pre. Okay. And that also is something that we check. Okay. So if you are feeling like alcohol is the best use or the best thing that helps you get through a long, hard day, that's a warning flag to me. And I'm also going to recommend that maybe you talk to someone about that and get into therapy. Okay. We want you to have good coping mechanisms after transplant, and drinking alcohol is not included in that. Okay. You will have some speed bumps. You will have some issues after lung transplant. So we want to make sure that you are set up for success where you don't feel like you need to drink to feel better. Okay. All right, healthy weight. You might have seen in the news, BMI is not the best marker of someone's health. Oh, yep, sorry. Yep, it can make you particularly jittery. And those who are post-transplant will know if caffeine can also give you tremors. And one of our main medications will also give you tremors. So that, I feel like sometimes boosters people to not drink a lot of caffeine just in that. But yeah, caffeine can be harmful to some people, and especially of large doses. It also might be a marker that you're not sleeping well. And in patients who have lung disease, when they come to see me and they're like, I can't sleep, or I'm needing to drink so many cups of coffee, it makes me think maybe you need a sleep study, like maybe you have sleep apnea, or maybe your oxygen levels are dropping too low at night when you're sleeping and you're not getting good quality sleep, and that's what's making you not sleep well. So caffeine, it's allowed. Technically, you don't have to stop it. However, if you're using it excessively, like I sometimes do when I'm like working in the hospital drinking multiple Celsius, that is not healthy. Do not do what I do with my caffeine use. Healthy weight, like I said, BMI is not the best marker of any sort of health. However, it's kind of the best we have for right now. I don't want you too thin. I don't want you overweight. Okay. It makes the surgery more complicated. Okay. So I want you right in that sweet spot between 18 and 30. Okay. If you're on one side of those things, we're going to counsel you to go to the other side. Okay. I'm talking too long. I'm sorry. So the transplant timeline, evaluation first. Okay. Then you're going to tidy up to-dos. I tell people almost everyone has a to-do. It's like very rare that someone will go through their evaluation. We're like, you are perfect. You are ready to go to be listed for lung transplant. Nope. There's going to be something you're going to have to do for us, whether that's more pulmonary rehab, whether that's changing around some of your meds, whether that's losing some weight. Everyone has some to-dos. You do them, you get added to the wait list. Okay. It's a national list now. It's changed in the past few years where you are the sickest people across the country have the first dibs at organs that are the right size and the right blood type. Okay. You were added to that wait list. The timing on the wait list will vary by person. It will vary by your height, and it will vary by your blood type, and it will vary by how sick you are. Okay. If you are short like me and you have a O blood type like I do, you will be waiting on the list longer than someone who's average height and has a B blood type. And that's just because of how the list kind of works. I can answer that in more detail if you have questions about it. But expectations are you may probably will wait on the magnitude of weeks to months to get a lung transplant. People aren't waiting years. Okay, that's extreme, and we are doing something. We're either switching you to a single or something's happening. Like people don't wait years on the list. Okay, like you might hear for other organs like kidneys. It's usually in the magnitude of weeks to months. It can happen in days, and that also sometimes happens, right? You get listed, and then we call you in the next 48 hours saying, we got lungs for you. Are you ready? So you better be ready. And we will talk to you about that before we list you. You need to be ready because it can happen at any moment. As I mentioned, you wait. This is probably the hardest part for you and us. We're just like, where are the lungs? I just want to transplant them. They've been waiting. You wait, you wait, you wait. As soon as we have something that's suitable, we'll call you in. We are not going to put bad lungs in you. So we will wait until we find the perfect lungs. Okay, call you in. You come in for transplant. We do it. Single versus double. Okay. You come out. You recover in the CT-ICU. That's our cardiothoracic ICU. You'll have the breathing tube in, some tubes, draining fluids. That's where we watch you to make sure that nothing crazy bad is going to happen to you. Okay. Once you're stable there, we move you to the floor. The 9th floor of our hospital. That's the transplant floor. That's where all the transplants who aren't in the ICU stay. And we watch you recover, get you ready to go home. Then you go home. Okay. And then you see us in clinic a lot. Okay. So it's one of my favorite things about doing lung transplant is that I get to know some of you, all of you really well. And it's like the best part because I don't just get to ask you about your meds. I'm asking you about your dog. I'm asking you about your recent trip. That is my absolute favorite and why I love doing lung transplant because the bond to me is just amazing. And so you'll see us in clinic. There are 5 of us now. So I know some of you older ones, a couple of us have joined now. You don't see some of your old favorites as often now, but you'll see one of us in clinic or our physician assistant, Jenny, who's also wonderful. And we help make sure you're not having too many complications. Okay. And then also importantly, you come back to pulmonary rehab and you get to show off to everyone how great you are with your new lungs. Okay. This is obviously very abbreviated. There are definitely way more than this, but for time's sake, it's kind of what I had to present to you. Life after lung transplant. Again, I hope, expectation and hopes are that you're off oxygen completely. It might take some time. It might not happen for everyone. This is our hope. Okay. And this can hopefully lead to a better quality of life. Whatever it is you want to do, I want you to be able to do it. Seeing and playing with your grandkids or your children or traveling or whatever. That's what I want you to do. And that's what I hope lung transplant affords you, the ability to do those things. Lots of clinic visits, as I mentioned, lots and lots of clinic visits. Okay. With that, lots and lots of meds. There's a lot of meds that go into keeping the lungs functioning. Unfortunately, those meds have side effects, so you need more meds to take care of that. It spirals, okay? 10 plus every day at least, probably more, okay? Especially earlier on. We dial them back as we can. It's a lot of meds, so if you don't like taking meds now, get over it, okay? It's not optional. You miss meds, you're nauseous, you vomit, you're calling us because it could be life-threatening if you miss medications, okay? You might need more procedures in the future, so just think about that. You might not just be the lung transplant and that's it. If you have bad reflux, you might need a surgery on your stomach to kind of fix that. Just be mindful that, you might need more stuff done to you to kind of, keep the lungs functioning as long as possible. You need to be admitted time to time to treat rejection, etc. Okay, not the end. You'll see us a lot. You might see us a little bit more frequently here and there, but overall, so hopefully feel better in the grand scheme of things. And then unfortunately, lung transplants don't last forever. And so I really try to tell people that what I want to maximize for you is the quality of life while you have it. Okay. Is my best case scenario you live a fantastic life for years and years and years and years to come? Yes, obviously, that's what I'm going to try to do. But unfortunately, no lung transplant patient lives forever. Okay. And unfortunately, the outcomes for lung transplant are the worst compared to any other transplant. And that's just because of all the immune cells in your lungs, the amount of immune suppression you need, et cetera. Okay. So it's not forever, but maximizing the time you have, making it the best it possibly can be. Okay. That was a lot, especially towards the end, because I realized I went way over time. I'm so sorry. Yeah.
I know, again, but I have 2 questions. One of them is the meet and greet that you talked about. You said when people first go for a transplant.
Oh, yes.
Is that something you can do? I read that should be done right after diagnosis. I've been diagnosed 3 years now. When would that be an appropriate thing if you're doing one?
Yeah. So that's something you talk about with your primary pulmonologist. They'll refer you and basically have us decide. Usually the things that push us is oxygen. You are ILD, IPF, which ILD, IPF. Okay. So usually if you're starting to need oxygen, especially with exercise or at rest, that's usually a major red flag that you need to come see us and talk to us. But like I said, some people just kind of say the same. So it's a conversation for you and your pulmonologist. Say, hey, am I ready for a lung transplant? And they might say yes, no, or I don't know. And if they say I don't know, that means place the referral. We'll see you and talk to you. I always prefer meeting people beforehand because the conversations are easier when you're not that sick. When you're really sick, it's harder to have these conversations about risks and benefits because you're like, oh my God, I'm sick, I'm dying, right? It's a lot harder. So earlier is better for us because we can say, you know what, you're doing great. We'll see you in 6 months, we'll see you in a year to make sure you're still doing great. Yeah. Oh, I know. I hope this wouldn't come up. I know it didn't want to come up. So we do not have an age limit here at the University of Colorado. The oldest person we transplanted, I think she was 76, 75. No technical limit, but the older you get, the more chances you are that you have things that are going to complicate things and make it more difficult. But everyone's individual. We don't feel like it's fair to say that every 74-year-old is the same across the board. So we will eval you and based on our recommendations kind of go from there. So we don't have a technical age cutoff, but it's very rare. Well, it's rare above 74, 75, we're getting real nervous that we're not doing you a good service and that you might live longer with your native lung disease if it's okay than doing a transplant.
Thank you.
Yeah.
Development of the anti-rejection personalized.
Are you talking about the inhaled tacrolimus? Yeah, so I'm super excited about that. It's not ready yet. Boo. I know. So the idea is that you, for those of you who are post-transplant, the idea is that instead of taking the pill, you would inhale it. It would go into the lungs where it needs to be most, and it shouldn't be absorbed systemically, so it shouldn't hurt your kidneys as much, probably. Yeah, still in the developmental phase, but don't you worry. As soon as it gets like approved, you better believe I'm going to try to get it for everybody. Yeah, when we went, so there's a big heart and lung transplant conference every year somewhere in the world where actually literally all the world people who do transplant come. This year was in Prague. I didn't get to go, I had to work. But of course, Dr. Gray got to go because, you know, she's the boss. And so she was in Prague and they learned about that. And that was one of the things that they talked about, some of the studies that are hot off the presses. Also hot off the presses is, and some of you are probably enrolled in our study, I think, actually looking at a blood marker for rejection. That's a little bit better than the bronchs that we do. That's also in the works. Oh, RATG. It depends on your body, but usually that lasts, I say months at least, usually around at least 3 to 6 months, sometimes longer. We'll test you to see whether that has worn off or not, but it usually lasts for months. Yeah, I ain't getting too much in the nitty gritty because I knew I was going to have a mixed audience. And I didn't really know how much I should talk about what part, because I wanted everyone to get something out of it. I hope you all did get something out of it, even if it's reinforcing things that you already know. But yeah, I hope it was helpful to you. And I'd love to come see you in clinic if I don't already, because I know I already see a lot of you in clinic.
Thank you.
Yeah, of course, of course.
Does anybody, Billy, you're new. You got to register your vehicle so that way you don't get charged for parking. And I also wanted to ask you guys, next month, October, it's usually when in the past we've had our potluck slash Halloween slash costume contest. You were part of that, yeah. So yeah, you win. So I'm gonna maybe send an email see if you guys want to do that. I know want to kind of get together. We don't meet on November because it's close to Thanksgiving. We don't meet in December because it's close to Christmas. And so that's why we kind of chose October to have that potluck and celebrate November, December, and then not meet again until January. So I'll send that email and see what you guys want to do. But the craziest will be done is actually if everybody brings their favorite dish so that we can share. And then I'll be ordering some more food from the cafeteria. And yeah, we'll make it fun and we'll have some prizes and yeah, celebrate and be happy, right?
Yeah.
Any questions, concerns, complaints, rumors? No?
That's true.
Guys, well, thanks again for coming in. I appreciate you and stay tuned for that email that I'll be sending.
Yeah.
Yes, thank you, Hector.